We are broadcasting, recording, and ready to start.
Greetings, everyone. My name is Leslie Thompson, and I am the CEO of Health Standards Organization and Accreditation Canada. I'm absolutely delighted today to be participating in a fantastic conversation that I know you will enjoy because it is so topical and relevant to the challenges that we're all facing today. This webinar is brought to you in partnership with Accreditation Canada, Health Standards Organization, and the Canadian College of Health Leaders, and we're so pleased to be here with all of you today. Our format is going to be one of conversation. I'm going to pose some questions to our fantastic panelists, and we're going to build off each other in terms of exploring some of the what's, the whys, the hows of virtual care. And we look forward to your questions and engagement in this session as well. We're all learning a little bit with the technology, so we'll apologize up front if we don't get it completely right, but we're going to certainly do our best. And without further ado, I'd like to welcome and introduce our panelists. You've got their amazing bios in the advertisement for this session, but wanted to introduce Mathieu Jackson, who is, you can just wave to everyone, Mathieu, who is who's a patient partner, brings incredible experience through patient partnerships and the university and his lived experience as well to this topic. And Eric Gombrich is got extensive background and experience from the technology world, and is going to bring that lens of the digital landscape to our conversation. And Laurie Poole, as a senior leader in healthcare for a number of years in a variety of settings, and currently with with Ontario Health and the Ontario Telemedicine Network. So we've got quite a gang. And why this group as well? Well, it also tied to the mandate here of each of these folks have participated in the creation of what is now Canada's first and only national standard on virtual health that has been designated by the Standards Council of Canada and Health Standards Organization as this national standard. They were part of the technical committee that helped develop it, looking at the evidence, experience, and looking to the future about how we can continue to evolve and adapt in this important space. So it's really timely now as we all face the realities of COVID-19 that has put virtual health in the spotlight like never before. People describe now the genie's been let out of the bottle and a lot of good can come out of the attention on virtual care. But let's dive right in and start the conversation with Mathieu. I'm going to start with you. Why is virtual health and virtual care so relevant right now? And why is it so important for us to learn more and do more about virtual care?
Well, thanks for the introduction, Leslie, and thank you for having me on this panel. Obviously, with today's circumstances with the pandemic, it's become clear that we all need telehealth more than ever. But I think what's interesting about the present circumstances that telehealth, I think from a user perspective, has been something which seemed quite obvious for a long time. It seemed like, and I remember just from the great conversations we had on the panel, on the committee building the national standard, from being there as a patient and user, I was very surprised sometimes by the conversations, and I learned a lot about why certain things which for me, like a phone call or a Skype call now, is already something which is completely part of everyday life. And there was always this thought of, well, why couldn't I consult my healthcare team, more regularly and more often on the phone or on a video conference? Why would that be, why would that not be a given? And now we're plunged into this situation where it is now the norm. So I think it's very interesting, and I'm looking forward to talking with my other co-panelists about it.
Leslie, you're on mute.
That's the classic line of the COVID time. I'm on mute. Sorry about that. So Eric, over to you. So telemedicine's been around a long time. Why is it so important to be focusing on this topic right now?
Yeah, so thank you, Leslie. I echo a lot of what Mathieu said. But I think the other thing that's driving this, like you said, it's been around for the better part of 20 years. In some cases, even longer than that, depending on your definition. But it's a matter of necessity and will. There has always been interest in it. I think for the most part, historically, what we've seen is the motivations for trying it have generally, and this is a generalization, but have generally been driven by trying to meet the needs of patients. But what's happening now is it's not just about meeting the needs of patients, but meeting the needs of physicians. If the patients can't come to the practice, as we know, a lot of physician practices are now concerned about actually remaining viable from an economic perspective. Perhaps not as crucial in the context of acute care in a hospital and what they may be doing, but in primary care and other private practice-based models, if the patient can't get to you, you can't bill, and if you can't bill, you can't pay rent and keep the lights on. And so there's a necessity now for physicians to use this as a way of not only providing support to their patients, but also, like I say, keeping the lights on in their practice. And I think that's the major thing that has changed and instigated or catalyzed this movement.
Lori, you've been working in this space for many years and have seen the evolution of telemedicine from an idea to something now that is scaled beyond, I think, anybody's wildest imagination. Certainly, it was hoped that we would see scale, but this has unlocked a speed that we hadn't quite anticipated. So, from your kind of looking back to where we are now, why is this so important and so relevant right now?
Yeah. Thank you, Leslie. Yeah, I mean, it's really been quite remarkable. I've worked in telehealth, and we now kind of called it virtual care because it's grown, and I've worked in virtual care for over 20 years, and I have a nursing background, so have seen firsthand the benefits for patients to receive care closer to home. So I've always been a huge advocate for virtual care, and it was really an amazing experience to be on the technical committee that actually refreshed the standards for virtual care that were developed a few years ago. So as Leslie noted, I work at OTN, and we are a provincial telemedicine network. We've actually been around for 20 years in Ontario. We already were a very large network, but since March 1st, we have seen an unprecedented demand for virtual care. And I just thought, to set the context, I would share with you just some of our numbers. So last year, over a 12-month period, we had about 1.1 million virtual visits on our network. Since March 1st, we've had 292,000 virtual visits. So that represents a third of our activity that we had last year has happened in a 6-week
Wow.
period. We've onboarded 15,000 healthcare providers since March 1st. That's on top of the 70,000 that were already using our network pre-COVID. And just to give you a picture of an average day, before the pandemic, we would have on average of about 1,000 virtual visits per day. Now we currently have between 11,000 and 14,000 visits per day. So that is just really an unbelievable growth and demand for virtual care. And we're actually enhancing our technical infrastructure because we expect that capacity, is going to grow. And in Ontario, I think we were pretty fortunate in terms of timing, because last November, the government actually introduced a digital first for health strategy. And as part of that, it included new funding for virtual care, along with the fee code for physicians to be able to bill to do video visits directly into the patient's home. So since March 1st, when the pandemic started, about 75% of the visits on our network are directly into the patient's homes. And that is very important because most physicians' offices are closed, and they're now able to use a secure channel to be able to see patients directly into their patient's home. So that's great security for patients to know that they can continue to see their healthcare provider, during these very, very challenging times. And as we know, video is just one aspect of virtual care. We've really seen tremendous growth in all of our other programs as well. One being e-consult, where a provider can send a question to a specialist. We've now enhanced that so a physician can send a question to an infectious disease specialist to get timely information. We've had a remote monitoring program for 11 years in Ontario that was really focused on patients with chronic diseases. We have 2 regions in Ontario that are now doing COVID home monitoring. So those are for patients that have been in assessment centers or have been hospitalized, can now get home monitoring from a nurse 7 days a week. We're also very busy working with Indigenous communities, with the long-term care sector, with palliative care providers, to really look at models of virtual care where we can help them better support people in their homes and their communities. And lastly, this is a very anxious time for a lot of people, and we have mental health programs that are available virtually, one being Big White Wall, which is an anonymous peer support program that you can access online. It's free to the public, and we've actually seen a 400% increase in registrations since March 1st. So, and that's just the activity that we know that's happening at OTN. There's lots going on, with other providers as well. So we expect this volume to increase, and we just feel very fortunate that we're able to provide, this provincial network to healthcare providers and the public.
Thanks, Laurie. And we know that there's, a great deal going on in many provinces across the country, and indeed around the world in many different areas. And I'm struck by a good paper that was written just a little while ago and updated around virtual healthcare is having its moment, and by Will Falk and Sasha Bada and others through CD Howe. And they actually talk about kind of this as, with the risks of physical contact. I mean, the risks of contact as being one of the drivers that is to this movement and the expansion. But with that risk comes the opportunity of creating an experience for people that has some closeness and almost the intimacy, if you will, in terms of a connection with people. I had my first video consult of just a couple of weeks ago where I had hurt my neck. And so I had a virtual physiotherapy visit. Never in my wildest dreams would I have thought you could do a virtual physiotherapy consult. And it was amazing. And my neck feels fantastic because of the advice and the intervention I had. And I was able to get it quickly. Mathieu, from your experience, and you've been using kind of virtual visits through your own health experience for a while. What makes a good experience for virtual care from both kind of the receiver and the giver?
Well, I've been, as you mentioned, I've been using virtual care for quite a while. I have hemophilia, and in hemophilia care in Canada, and I think in many countries around the world, we've been using virtual health for quite a long time. We've tried different things. When I grew up, I had, because hemophilia requires regular injections, and it's a lot of monitoring. So a day-to-day management of the illness. And so for a long time, we used paper calendars. When I was a young kid, I would give myself my shot and then write it on a calendar, and then meet my health professionals twice a year. And then we would go over the paper calendars together. And we've tried different solutions and different applications. And the latest one has really took off and been very successful. And actually the same template has been used in Australia, and in other countries as well. It's called MyCBDR. And I think that the main difference is that the tool, so it's an app that offers all kinds of different tools, not only for the healthcare providers, but also for the patients. The patient community, the Canadian Hemophilia Society, was involved since the very beginning of the project. So there was that patient input and perspective since the beginning. Other applications have come and gone, but they were really focused around the clinic, and so collecting data for just clinical monitoring. And one of the examples is that the patients in the meeting said, "Well, why wouldn't we have access to those graphs? You know, you guys can pull up all these interesting graphs. I could use that in my own care." So that's an example. And I also work at the Center of Excellence on Partnerships with Patients and the Public in Montreal, and as a patient partner. And we've also accompanied many different virtual health projects there. And that's, I think, what we tried to reproduce. For example, we worked with the ministry on the online patient records, developing the portal. And I wasn't directly involved in the project, but my colleagues, Sylvain Bédard and Karim Skirej, who were in charge, who are a tandem of professional and patient partner, really did a great work to develop a whole trajectory of the patient experience over life with all types of different patients, and really trying to incorporate that perspective since the beginning. So I would say that if you want it to be long-term and you want it to work, and you want, basically, I don't know how we call it, maybe my co-panelists could help, like virtual compliance in a way. Because for it to work, the patient needs to use it. You know, if you don't use it properly, you're completely beside the mark. It's just like any type of treatment. It becomes part of the treatment, I guess you could say. So for that to work, it needs to work for patients. It needs to work for people who are living with this illness, who have to use this on a daily basis. So that's what I would say. So education and partnership with patients and with communities as well, patient communities.
Thank you, Mathieu. And Eric, you've been working in the technology space and have seen lots of changes with the way kind of various platforms have emerged and going forward, and everybody in their rush to moving out there right now. And I know you talked about this a lot in the development of the virtual care standard. What are just some of the brief kind of overview of what are the considerations from, you've got privacy, security, usability, there's all kinds of things, and we're not the deep kind of technical review here, but there are some things that might be important questions for if you're a patient or a citizen to ask about what's happening with maybe their virtual care provider, or if you're planning the development of virtual care services, what are some of the essentials that need to be there that provide a good experience from a technology perspective?
Well, it's a great question, and I appreciate you stressing the word brief. You know me too well. So
it's a complicated topic too.
Well, it is and it isn't. And the reason I say that is, one of the things that I've learned, we've learned, and just by way of background, that includes a number of years being with Providence St. Joe's Health, which is the second or third largest not-for-profit system in the United States. and one of the pioneers of using telehealth and telemedicine, throughout their 50 plus hospitals and 1,000 plus clinics. A lot of what we learned is it's not about the technology. And the failing is that way too many attempts start with the technology and think I'll implement some video conferencing capability and I'm off and running. And the reality is that, as we used to say when I was at Providence, think as though you are building a brand new hospital or a brand new clinic. You have to consider everything from the patient flow to the billing to everything else. So it's more about designing the service in the context of workflow. And that includes both, as Matthew just suggested, for the patient journey, as well as for the provider. And we're starting to see the friction, if you will, from a rapid jump to the technology and turning on the technology, with all due respect to OTN and others who I think do a great job of helping with the workflow. But providers just think, okay, I'll sign up and off I go. And they don't consider the fact that, wait a second, you now have 2 logins, one for your EMR and one for the video conferencing. How do you, there's even a question that was on the Q&A session here, how do you window level so I have access to my chart and the video at the same time? These are all, you would think, technical things. And the technology is really the way you answer the question, but you have to ask the question, what is it I need? If I need to be seeing monitoring tools, blood pressure cuff readings, blood glucose level readings from a patient device that's in their home, how is that going to present itself in the physician's user experience? That's entirely different than if I'm doing, a dermatology visit and I need to see images that are being uploaded from an iPhone. And so each of these use cases have particular workflows and therefore have particular demands on the technology. And I think there's far too much focus on the technology, particularly in the early days of trying to get started, rather than thinking about what is our workflow. And I think one of the other things, to just summarize and conclude with this, the other thing that's, I think, a common barrier or risk with a lot of these efforts is a lot of physicians or organizations that are trying to turn on virtual care or telehealth are trying to replicate the experience for both the provider and the patient that they have in a face-to-face world. That won't work. That is, the equivalent is saying, okay, this is how I chart on paper, and I want the EMR to do the same thing. We all know how that's turned out. This is an opportunity, I think, for physicians, for practices, for administrators to really think about, why do we do the things the way we do it now in a face-to-face world, and what of that should we carry forward, and what of that should we change as we move into a virtual world? And the technology is merely an enabler to that.
Thanks very much, Eric. And don't just automate the model that may or may not have been optimal into this virtual care setting is one of your biggest messages. And Lori, in your experience of kind of ramping up and rolling out the virtual care at with speed and scale, what's been your biggest kind of learning and feedback from people around kind of what can make the experience work really well, if we start there? And obviously there's real challenges as well, but from that experience and feedback you've had both from providers as well as from the patients and families and people who are having virtual care as their mode of care.
Right. Yeah. So I just, my dog just joined me. So
I love it.
With me, the realities of working from home. She likes to be beside me, but yeah, no, it's a great question, Leslie. And I think I need to echo, what Matthew and Eric have said, is that, it's really understanding what is the problem we're trying to solve. And so, while we've been doing virtual care for a long time, suddenly we had a pandemic and we had to come up with solutions very, very quickly. And so, I believe that this pandemic is going to continue, for a while. Post-pandemic, we're still going to do, a lot of virtual care. But at some point, we're going to have to try to take that collective kind of breath and pause and say, okay, what are our learnings? What are those clinical use cases where patients truly benefit? And there are some things that are fundamental to our healthcare system. So patient safety, security and privacy, that trusted relationship, with your healthcare provider. What Canadians believe are really important about our healthcare system. We have to make sure that we can sustain that, with virtual. And we know that virtual is not a panacea, for all care, that there are still many situations where patients will see, a healthcare provider in person. But I do believe, we have turned a corner around virtual care becoming just care, right? I always say that I know my job will be done when I can just don't have to say virtual care. That is just care, and that is integrated into our healthcare system. And I think very importantly, we have to connect the dots, is that virtual care has to be integrated into the patient's circle of care, and there has to be links back to that primary care provider. So I think those are, some of the things that we're experiencing now. It's a bit in the wild because there's so much happening, but I think we need to kind of pause and step back when we have that moment to say, what are the key learnings? We know there's lots of benefits, and then how do we integrate this into our broader healthcare system? And what are some of the policy, leverages that we need to have to be able to support that?
I love the notion of kind of virtual care is just care, and getting to that kind of real kind of new normal. One of the things that Zaina Kayat, our kind of Canadian futurist in healthcare, was talking about yesterday, was saying it's really kind of patients and families and the public that are going to pull us forward and help make sure that that this really is the new normal. I've seen a lot of questions from people, and I thought maybe we could take a couple of those as we kind of pause here, take a few of these questions, and then we can continue further. So one of the questions is around this kind of notion of we're in a bit of a low rules environment right now. And that's really become a significant enabler for moving forward. How do we kind of balance out taking the lessons learned from this, maybe fixing what needs to be fixed, but also making sure that we are able to continue to grow this approach? Mathieu, you've probably seen some different experiments with this. What might be your kind of advice and in looking forward of how to shape the experience of the future? Well,
once again, I think that if patients and communities are involved at the very beginning, then of the process, beginning of the development of these tools and implementing these new ways of working, I think that's the best way to guarantee a certain a duration in time, and I think that it's going to happen anyways, because I wrote down a note saying the chicken and the egg. I was thinking about this conversation before, but for instance, in the hemophilia community, as I said, we've been using telehealth and tools for a long time, and so patients have become very empowered in their own care, and the role of the clinicians, the role of the clinicians is just as important. Of course, we need them, we depend on them. However, the role of the patient in their own care has just grown and grown and grown, and so I guess you could call it sort of patient empowerment or something like that. But is it, and definitely virtual health has that effect, because you're no longer as dependent on the clinic physically. hemophilia patients are very dependent physically on the clinic, but health technology, so new products, but also virtual care have allowed patients to be less directly dependent on just on a physical level, dependent towards their healthcare providers and the clinic. So is it the health technology which allows us to be more empowered, or more empowered community and patients will sort of push for that technology because it's going to allow them to kind of emancipate from an illness that can be very repressive, and it can keep you from living a healthy life, and in the sense of a fulfilling life. So I think it's kind of like the chicken and the egg, but the more patients get empowered, I think the more they're going to want these tools, and the more you give them the tools, the more they'll get empowered. So it's a rolling ball, and it's going to keep growing, I think.
Thank you. And building on that, and someone else, looking at it from the kind of the professional environment and setting up your clinics, and you could be a physician, a nurse, a healthcare team. There's every profession can be involved in this. How do you actually kind of set up and think about the delivery model that you're going to provide? Eric, I'm wondering, you talked about some of the thinking through the processes and thinking through kind of how do you actually set this up as a new way of delivering care as a provider. Any thoughts from your experience on that?
Yeah, it's along the lines of what I was suggesting before. I think it's a whiteboard exercise, probably with a group of stakeholders, including, if I could overly simplify it, the physician, of course, perhaps the nurse, the MOA, or the office manager, if you will, the clinic manager, and then at least one patient representative. And the patient representative probably, you may need more than one depending on the use case scenarios. It's different for Matthew in managing his hemophilia than it would be for an oncology patient. And yet again, for somebody else that, is dealing with anxiety or depression or, suicide risk. Those are 2 or 3 very, very different use case scenarios. And so it's a matter of sitting down and just mapping out the journey. For example, and I won't go deep into this, but as a physician, I wake up in the morning. I'm not a physician, I'm pretending in this context, bear with me. I wake up in the morning. Am I going to walk down to my office and open my laptop, or am I literally going to get in the car and go to the office to do telehealth or telemedicine? Let's start with that, because that will impact the decisions that need to be made about bandwidth into your home versus into the clinic. Do you allow, with all due respect, Lori, I'm just suggesting the dog walking in the background, because if I am a psychiatrist and I'm dealing with a patient that is having schizophrenic issues, we may not want to let have animals walking around to the background that they start worrying about. And so you just starting that part of the process to map it all out starts to dictate that use case and the technology and the infrastructure and the security considerations and the environmental considerations and all of those things. And I think that's where it starts. I think that's really the thing that we're skipping past way too quickly as we grab technology and try to replicate face-to-face experiences.
Lori, kind of building on those pieces of kind of successful ingredients, one of the real some of the real beneficiaries of this has been for people who live in remote and rural populations. And somebody had made the comment online around how that's kind of really kind of opened up connections. It also gets at some fundamental issues around equity. And I think this whole COVID situation's actually put a real spotlight on vulnerable populations and the inequities that actually exist in our models of care and our approaches to care right now. What have been the learnings around connecting with people in ways that maybe hadn't had access before to virtual care and that have come on board? What's that teaching you about the value of virtual care?
Mhm. Yeah, you know, equity and access have always been very, very important components of virtual care and healthcare, like in general. And you know, we just assume that everybody has access to, you know, a mobile device or a PC in their home, and that is just not the case. We've seen that over the years in terms of ensuring that if we are providing virtual care, that we understand, you know, equity. And we've had experiences when we've been launching with some hospitals the home monitoring for COVID, and realizing that some patients don't have a device in their home, so they can't enter, you know, they can't answer questions. And so we pick up the phone, right? You have to understand, you know, what patients are capable of doing. You have to consider language barriers. You have to consider social isolation. You have to consider that there are elderly people that are living with an elderly spouse and may not have access to a family member. So those are the type of things that when you're setting up for a virtual visit, those are the type of questions that you have to ask. And that is very, very important in terms of not forgetting. And I think it goes back to something that Matthew said, is that, you know, understanding what the patient needs and what the patient has. And I know when we talked about developing the HSO standards, that was one of the things, is understanding the patient orientation, right? And then developing that care around those patients.
Thank you. One of the other questions that's popped up is around in virtual visits, what's the role, and how do you start thinking about what's the role of including family members, support team members, and making sure that it's a modality that's accessible to people that might even have visual or hearing challenges. But let's start with the the family and inclusion. Does this help as an approach? Again, one of the challenges of the contact in the lack of contact in the acute setting, we've really had some real challenges and some very, very heart-wrenching stories of people who are separated from their loved ones. How do we balance? You know, one of the other themes that I see coming up in the questions as well is related to this, is almost the balance between inclusion and privacy. But let's start, Matthew, on terms of the notion of inclusion, and from a patient perspective. How do you decide what's going to be right for you, and what value does this new modality offer you to be more inclusive if you choose?
Well, I think that I'm a sort of not a very representative of the general population, in the sense that I work in an academic setting. I work full time as a patient partner, and not much people do this. And I'm on committees like this. I'm extremely lucky to be on committees like this, but of course I learn a lot. And so I don't think I'm a representative of sort of the average Joe. But as a patient. But I think that one of the, and we've touched on it a little bit, when you're talking about equity, I think two really important elements are communication and education. And I think that, for example, I'm not sure how it's been exactly in the other provinces, but I know that in Quebec, one thing that the government has been doing well is the communication bit. So we've had, daily updates and answering questions every day. And that one example that comes to mind is regarding this MyCBDR app that we use in hemophilia. I was in a presentation and there was a hemophilia patient that got up and asked and said, how do you know? And he was very concerned about the Russians getting our data. And he was convinced that he refused categorically to use virtual health because he was afraid of the Russians getting his data. You know, that's, I think, a perfect example of where communication is so important. You know, a guy who lives in a rural area, a little bit outside, doesn't use any technology in his daily life, not sure, you know, the level of education, etc. So, you know, he saw in the news that there were some Russian hackers or whatever, and it was during the Trump election, so that was on, you know, the front pages a lot about Russian hackers and getting involved in the elections. But of course, this is not presidential elections, you know, and so I think that at that level, you know, the best way to communicate with patients directly is through those community outlets. The same goes with education. So, you know, there are all types of different challenges and issues with different populations that it's hard. You can't really, you know, you can't really foresee them. You can't really, but however, and I think that this has been shown also in the literature quite a bit on patient education, that there's no one better to teach a patient how to live with an illness than another patient that lives with the same illness. Just like Eric mentioned before, you know, I could not teach someone with diabetes how to live with diabetes, although there are probably some similarities, or someone with cancer. So I think that education and communication are very important, and there's no better way to do it than with patients and patient communities.
Laurie, what's been the experience from OTN in terms of including patients and families and the kind of the design and the rollout, and what are you learning around this opportunity to include more folks in that care encounter if that's what people wish?
Yeah.
What are some of the insights and learnings?
Yeah, so, you know, OTN started 20 years ago, and it really was, it consisted of, you know, big video conferencing equipment in hospitals and patients going to hospitals and linking to a specialist. And now we have virtual care that is, you know, directly into the patient's home. And so when we work with the healthcare community on a new model of virtual care, they're bringing patients, you know, to the planning table, which truly is remarkable, because then you really understand what is important to them, not what's important to OTN or to providers, really what's important to patients. And, you know, there's been some amazing experiences that we've learned as a network provider in terms of going back and working with the vendors around the usability, you know, for virtual care. When we rolled out remote monitoring many years ago, the screen, the font on the screen was too small, and an elderly patient said, I would never be able to read that. I need the buttons to be larger, you know, so those type of things, right? And we hear a lot more about co-design, and it's really designing, you know, virtual care and really any new technical solution around the needs of the patient. So I'm just really excited to see that we have much more patient engagement and patient advocates that are saying, if you expect us to use virtual care, then this is what we need to see. But I'm also seeing that shift with healthcare providers as well, with clinicians that say, look, you know, if you want me to use video, I already have video in my EMR or in my hospital information system. So there's a rollout within Ontario to be able to develop standards for all virtual solutions and not just OTN, right? OTN did it 20 years ago because nobody else was doing it, but we don't develop technology anymore. We're really a steward for virtual care in Ontario. So the development of standards and that governance around those standards to ensure that those solutions, you know, use a co-design approach, that they're private, that they're secure. Those are the things that I think as we kind of get out of this pandemic that we'll go back to in terms of the sustainability of virtual care moving forward.
Eric, any additional thoughts on this this point, and particularly, are you aware of some of the questions around looking at connecting multiple sites, connecting people across the trajectory of care, across the patient pathway? How do we kind of look at the virtual care as an opportunity and a platform for this overall integrated experience of care, bringing the care team from multiple places together along with the individual, not just the one-on-one of the traditional clinic visit, because as somebody's pointed out here too, we don't want to replicate the patient going from building to building, clinic to clinic, which is one of our biggest problems today. How can the virtual care tools and supports kind of help us pivot to this new, integrated, connected, inclusive, as well as efficient, more efficient model of care?
It's not an answer that I think is going to cause people to relax. I think Lori's right that it's very standards based. I think we can use an analogy, and that is if we think about the cell phone and the cellular network industry. I may run out and choose TELUS or Bell or any other carrier, including some of the ones from international or overseas, but they all talk to each other. And we've created a metaphor on the phone with 10 buttons, and we all know how to use it, and it doesn't matter whether it's Samsung or Apple or anything else. Now they all have their own little nuances to them, but generally I can use an iPhone, of course, on the Bell network to talk to somebody on an Android device on the TELUS network. And there are efforts to do that within the technology, particularly WebRTC is probably the most current standard, if anybody cares about that. But choosing a proprietary video infrastructure is actually going to create that barrier that you're asking about how do we avoid. And so I think looking for infrastructure that is interoperable is a key thing to consider. And then you also get into the user experiences, which is like the 10-button phones that we all have. I think we need to simplify some of the user interfaces, even as we've seen in this call. There are a lot of people using chat to post questions, and then there's also the Q&A. Why are we giving both options? Let's simplify this for patients so they have fewer things to click on. Just unify it so it's the same regardless of whether I'm using video spelled with a Y that's embedded into the Epic instance, or I'm using Zoom directly in my private practice. It doesn't really matter. But it's all about the user experience, which is the user interface and the workflow. And I think that's the answer, and the technology needs to be interoperable from a standards basis, and that'll enable that.
Really appreciate all the insights, and there's some fantastic questions that are kind of continue to speak to the challenges, the opportunities, trying to imagine how we move from here into the future. Wanted to also just flag for all the participants that some of when we talk about the Health Standards Organization, the HSO standard, which now has been designated by Standards Council of Canada through to the Government of Canada as a national standard of Canada. That is available, and we will and you can we've actually provided no fee access to that during COVID, because it's how important it is and how many questions that we're getting on this. So this is something that's out there. But where you also might be really interested is that there is a series of toolkits that are there that actually speak directly to the advice and the perspectives that the panelists are bringing. And the toolkits are for patients who are participating in a virtual care encounter, for health professionals that are actually providing virtual care encounters and mixed care, and for digital teams who are building those frameworks. And there's a set of kind of taking the most actionable criteria from the national standard simple checklists of saying, okay, do I have these things in place in order for, if I'm a patient, for setting up my technology, for knowing my privacy, safety, and confidentiality rights? How do I get ready for a virtual care encounter? How do I actively participate in it? And how do I follow up effectively? So that's the kind of level of specificity that's there as a guide. And so encourage people that no matter what setting you are you're working in, there are, of course, many kind of tools out there, but this one takes the best out of the standards and the advice of evidence and experience and experts to provide you with something concrete that you could use today. And so encourage you all to do that. And we'll make sure that you've got the links there. And it's the ability to share that with you is because of the great work and expertise of all the panel members. Eric.
Yeah, if I could just jump in, and I hope I don't get myself in trouble with my fellow panelists. I don't think I will, but you know, OTN, I think a plug for you, Lori, and your organization have done an incredible job of pulling together some of these resources over the 20 years you've been doing it. But two other organizations that I would suggest that people look at, setting aside nationalistic proclivities, would be the American Telemedicine Association, ATA. They have a tremendous amount of resource, including research and studies on patient satisfaction, physician satisfaction, all of that. And then the other one is HIMSS. Also has a prolific portfolio of resources and growing. So anybody that's interested in looking at it, now of course you're not going to see a lot of Canadian-centric context. So, you know, the laws and regulations in the US are slightly different than they are around privacy and whatnot here in Canada. But, you know, if you're trying to figure out how do I get going and what do I need to consider, it's all going to be the same. It doesn't matter where you're practicing.
Yeah, absolutely. And great points, because, and I love some of the work of some of these really kind of large and progressive organizations that start to speak to outcomes and to, and metrics. And we've got some questions from people that maybe I'll just kind of pivot there before our final wrap-up question, which is going to be, so what's the takeaway and advice for participants on this call? If you had one thing that you wanted to say as a message for them to start to think about, and about what their role could be in the future. But just before there, if there's anyone that wants to speak to any experience that you've got around the use of metrics and outcomes from the patient and provider experience related to virtual care. Yeah. Lori, I see you nodding. Do you want to jump in?
Yeah, you know, I mean, there's so many, but I'll just kind of point out a few. You know, in Ontario, as we move beyond kind of the core video conferencing, we've worked with many partners to develop new models of care using virtual tools, you know, for chronic kidney disease, for palliative care, for diabetes, for mental health. And as part of that, we've done evaluations. And these are not really comprehensive, you know, randomized controlled trials. They're really looking at programmatic evaluations. So the WEAVE team at Women's College Hospital have actually funded new and evaluated new models of care, and a lot of those reports have been published. So I would encourage the participants to check out WEAVE, and also at the government level, right? A number of virtual care programs, you know, have been evaluated. So those tools and resources are readily available, right? And so I don't think we need to start from scratch. We obviously need to look at what the impacts are, and most importantly, what is the sustainability, right? So it's one thing to do a wonderful proof of concept, but you really need to build in that business model, because many initiatives get one-time funding, and there's great outcomes, but you really need to look at the sustainability and how you're going to bake it into the healthcare system moving forward. Okay.
Such a just great, and I think all the participants, including myself, would agree that there's so many fantastic resources out there. A lot of people trying to collate them, and the key is to try and find what's going to also work best for you in your setting. And also to meet you where you are in your own development and working with your partners and others. But I think overall what we've heard from each of you is you really have to start with the patient, the citizen, the person who's going to be the beneficiary of that experience, and design your approach starting from there and with them included. That I've heard from all of you as a critical success factor. In the final 3 minutes that we have to wrap up, what's your parting message to everybody today about virtual care, looking forward and into the future? Eric.
Sorry, got to get off mute. The key thing I would say is the genie is out of the bottle, and I don't think we can put the genie back in the bottle. I say that because patients are going to say, you know what, this was awesome. Some patients are not, obviously, but I don't think telehealth, telemedicine, virtual care, however you want to frame it, like Lori was suggesting, I don't think it's a replacement for face-to-face. I think it's an option. In some cases, it improves access, all of that. And patients are going to respond to that, like Matthew was also saying, is, you know, they're going to start to demand it more. And I think the most important thing, if I could leave one thing for people to think about, is communicate with your patients now that we are piloting this. You are piloting this. You are trying it. Set up the expectation that things will change. We're all jumping in really quickly. We're slapping Band-Aids on processes and whatnot to try to continue to render care. And we will improve. We will get better. And we are setting precedent for patients right now. And the precedent is you can connect to me virtually. They're not going to let that go.
Matthew, you're the patient voice. How do you encourage and look forward?
Well, I would say be a humanist. Have faith in people. Have faith in patients and users to do the right thing. When people are in difficult situations, which, let's be real, having an illness is not fun. It's not easy, and it's a difficult situation. People will, I think, generally have a tendency to do the right thing and to acquire the tools to better take care of themselves. So have faith in the community and in users and patients. And if you, and just the last little note, if you want to involve patients in the process and you're not sure where to start, you can contact the Center of Excellence on Partnerships with Patients in the Public in Montreal. We're not a huge team, but
we're a great team.
We're a great team, and we do have lots of connections, so we might be able also to refer you to another group. So cepp.ca.
Fantastic. Lori, closing thoughts.
Yeah, I'll just say, you know what, I think my dream has come true, right? Like for many years I've been saying, you know, like virtual care. I think I'm now just going to say that, you know, care includes, you know, virtual. And I really believe, as tragic as this pandemic has been, we are going to have a better healthcare system. And it means that virtual care is just going to be integrated, and it's going to follow the patient. It always has to follow the patient. And my parting words would be, don't seek perfection. Like, do not seek perfection. We have learned a lot. We will continue to learn. So there are so many virtual care champions that are already there. So lean on your friends, lean on your community, and I think together we'll have a better healthcare system.
I'm going to ask that, I know that all those who are participating today, I know there are about 500 participants and viewers in our live session today, and many more will watch this afterwards as we make sure that the conversation is available to others. I want to first thank each and every one of you, Eric, Mathieu, and Lori. You've been fantastic. Can tell from all the questions and the feedback that people have enjoyed the conversation. They're learning, and they're continuing to encourage us to ask and address the real, kind of some of the provocative questions as well, and to look at what this new future can be. And I can assure you that Health Standards Organization and Accreditation Canada, we are going to do our part to continue to partner with others, to continue to provide the kind of resources and supports that can enable people to thrive in this really challenging time. I want to close by thanking the Canadian College for Healthcare Leaders. Thank you so much for your foresight of saying that this would be something, a topic, and for your members, and to be a partner in bringing this conversation to the world. So thank you all. Have a great day. Stay safe. Stay home. Wash your hands and be well. Bye for now.
Bye. Thank you.
Thank you very much. Thank you.
Thank you.
Hey, this is Amy O'Brien from the Canadian College of Health Leaders. I just want to thank everyone for joining us today and participating in this really great webinar. Thank you to the teams at Healthcare Standards Organization and Accreditation Canada for their work on getting this webinar together. Thank you to our panelists, Lori, Eric, and Mathieu, for their insight and knowledge, and for Leslie for doing such a great job at moderating. On this slide, you will see in front of you links on how you can connect HSO and CCHL and find relevant content and resources for COVID-19. We will be sending out the recording and a short survey to all participants. We would appreciate your feedback. So thank you, and have a great rest of your day.